to the demo.
This was really good.
In the chapter on acute coronary syndromes, you've learned how to use echo for the diagnosis of ME. But remember, after treating the vessel, your level of alert has to stay high because bad things usually do not come alone, and you have to watch out and care about complications of ME.
And in this chapter, we'd like to give you some advice of how to take care of patients once they have a myocardial infarction. And the first advice we can give you: keep an eye on the ventricle. I'm sure you remember this case that we presented to you in the chapter on myocardial infarction. It was the patient who had this huge infarct and developed cardiogenic shock. She died. Well, what is cardiogenic shock to start out with?
Yes, the definition is actually a decreased cardiac output with evidence of tissue hyperperfusion in the presence of adequate intravascular volume.
And it is the leading cause of death in patients who have myocardial infarction once they reach the hospital. And if you don't intervene, if you don't give them adequate treatment, the mortality rates are extremely high, somewhere in the range of 70 to 90%. Now, in general, what is the early mortality in patients following myocardial infarction in the first 30 days? Well, if you have a poor left ventricle function below 30%, the mortality rate is extremely high, especially due to sudden cardiac death. So they have a higher risk of arrhythmias. The risk is higher if you have a STEMI, in other words, a transmural infarct. The rate of death would be somewhere in the range of 2.5 to 10%. And the prognosis is better if you have end-STEMI patients. And what we need to know is that with the treatment that we have, and probably also with the refined diagnosis echocardiography, the prognosis of patients actually improved over the decades. And watch out for patients who have reinfarcts or who are unstable, because those are the patients who will probably develop complications.
And the ECG, of course, helps us to define the entity and the severity of a myocardial infarction. Look, for instance, at this example where we have ST elevation in all the anterior leads, and this, of course, suggests a huge myocardial infarction. You can also look at the enzymes, but see what echo gives you more.
I mean, this is definitely a huge infarct if you look at that echo here.
Yes, and actually, if you notice, there is some kind of smoke effect inside the ventricle. This is what we call spontaneous contrast, and it's a sign of dysfunction.
And not only a sign of dysfunction, but it also shows that this patient probably has an increased likelihood of developing a thrombus, also a potential complication which we'll discuss in this chapter. So the echocardiogram definitely gives you very important information. And if we compare these two echoes, both are patients who developed an anterior infarct. What is the difference between the two?
Well, actually, the function is still preserved in the ventricle shown on the left, and it's really reduced in the one shown on the right. So this is the main difference.
Yes, it's the patient on the right who probably needs more attention, more care, probably some form of diuretic treatment, and is at increased risk. And if you look at this example, again, a patient following anterior myocardial infarction, you see that his ventricular function is very, very poor. You could maybe see this massive ST elevations in this patient as well, but the additional information you get with the echo is the image on the right. You can see that he also has mitral regurgitation, which definitely decreases his prognosis even further. And we can also see that he is also developing right heart failure. We have a pleural effusion. We have poor right ventricular function. So we get so much more information with the help of echocardiography.
And now the second advice, focus on the injured myocardial infarction. Why? Well, look at this example. Here we can see not only wall motion abnormalities, but also a structure which is protruding into the left ventricle and has an echogenicity which is different from the one of the myocardium. I think you can understand this is not normal. As a matter of fact, it's an apical thrombus.
Yes, an apical thrombus are something you have to be aware of in acute myocardial infarction, because there are several reasons why a thrombus can appear. First of all, we have a region where there is less blood flow. So we have a state where thrombus can develop because the endocardium is damaged there. And patients with myocardial infarction also are in a hypercoagulative state. So all of these three factors together predispose patients with infarction for a thrombus.
And remember, this can happen in big infarcts as well as in small infarcts. For instance, here we had an anterior infarct involving the apex, and a big thrombus actually was generated.
So it's not necessarily have to be a huge infarct. Even small infarcts can develop thrombi.
And look at this other example. Is that a thrombus? Well, I'm not sure either. And actually, this is a case where I would perform a contrast study. We did it, we found out the thrombus was there, but leave it for now. This will be something you will learn in the masterclass.
Here are some facts about thrombi. The highest risk is in the first 3 months.
The incidence is in the range of 5 to 8% in recent studies.
And embolic complications are, thank God, relatively rare, only maybe 2 to 3% in the thrombolytic era.
And now our third advice, remember, thin, disruptive means at risk of rupture.
This is such a beautiful example. Look at the distal part of the interventricular septum right here. You will note that the myocardium looks kind of awkward here, thin and disruptive, but you will need color Doppler to confirm that there truly is a ventricular septal defect, an ischemic defect. You see the blood flow from the left ventricle into the right ventricle right up here. And this was a patient who actually had a repeat infarct. She was brought to the ward and after some time again developed ST segment elevations, a reinfarct with chest pain, and then was brought down to the echo lab, and this is what we found.
Yes, and actually we used also atypical views, and this is what we recommend you to better characterize the defect and be sure of it. And here, as you can see, is a tear with, again, the blood flow going through it.
Yeah, I mean, these tears can be very, I would say, strange at times. It's not like a hole, but sometimes a splicing of the interventricular septum. So there's all sorts of variations.
Yes, and here we have a case for you. Do you see here a ventricular septal defect?
Well, if you look at the interventricular septum right here, again, it looks quite awkward. There seems to be disruptive right here as well.
And another factor which could lead you is we have some kind of pericardial effusion, not really small amount. So this means it's not only myocardial infarction, maybe it's a complicated one. Right. And here we add color Doppler. And the answer is yes. We have flow going from the left ventricle to the right one. So yes, there is ischemic VSD.
Right, and there's two specific predilectation places where you have rupture. If you have an anterior infarct, this is where you would see the rupture. We saw 2 cases. And if you have an inferior infarct, it would be in the basal part of the inferior septum. Remember, that's the part that is actually supplied by the right coronary artery, and rupture occurs there in inferior infarcts. The one region is right up here, which is the distal septum. That's where you would have an ventricular septal defect that is caused by an anterior infarct. And the second one is further down here, where the inferior wall actually connects to the interventricular septum. This is usually caused by an inferior infarct. Now, if you want to image the VSD of the distal septum, I would recommend you to really see that you don't have any foreshortening. So I'm going down as far as possible, and then I use a slanted view, because if there's a defect, you would have blood flow that goes pretty much perpendicular to the flow to the Doppler beam. So you have to have a little angle to the Doppler beam, and then you would put the color inside and look for the VSD right up here. Of course, he does not have a VSD, but that's where you should be looking for. The second VSD would be you go to the 4-chamber view and then you tilt downwards that you are almost visualizing the coronary sinus. And then you would look exactly in this region down here at the base of the heart to detect the ventricular septal defect. You can also see these septal defects if you use a short axis view. Now, I'll show you the short axis view. Especially for the inferior infarct, that is the view you should be using. So you perform a short axis view, and then you try to image more or less at the base of the heart where you almost see the mitral valve. And frequently you would have the ventricular septal defect right down here in this region. This is where you would find the VSD. Often it's combined with a little bit of an aneurysm of the inferior wall. So you have a bulging out of the inferior wall, and you see this part of the inferior wall connects right to the interventricular septum, and that's where you would see the jet. So this is a very simple approach that you should use in patients where you suspect a VSD, because I've seen it so often that ventricular septal defects are missed, especially when they're small. Good. So we saw another complication, I would say a rather rare complication, which can occur, of course, but is much less common as cardiogenic shock. But are there other complications we have to watch out for, Anna?
Yes, and I will show you to you.
This is a pretty dramatic echo, and it's a subcostal view. We could not position the patient because, again, the patient was in shock. What do we see here? Well, we see coagulated blood right here in the pericardial sac, you see? And if you see this in the setting of a myocardial infarction, the diagnosis is clear. This is
myocardial rupture, and I can tell you something about it. It has a very high mortality. It's almost 95%, so most of these patients cannot make it to the hospital. Can happen also in small infarcts, and usually presents with tamponade or hemopericardium. So here is the diagnosis, as we said, it's myocardial.
It's actually a rare case. I don't have so many cases of myocardial rupture because, like Anna said, most of them die in the field. They don't even reach the hospital. If you look at the autopsy data, you see that the myocardial rupture occurs relatively frequent, or more frequent than we think it does, simply because we do not see them anymore because they do not reach the hospital.
But there are cases where the rupture is not complete. The patient may have a tear which is sealed by the pericardium. This is what we call pseudoaneurysm or contained rupture.
Right, these things are very difficult to diagnose because sometimes you don't see very much, only kind of a regional pericardial effusion, or as in this case, an aneurysm which was then perforated and sealed. Sometimes you need other imaging modalities, for example, MRI, but the main point is that you have to have the suspicion to bring them to this further diagnosis because they are also at increased risk of secondary rupture and they have a high mortality as well.
Yes, and this is how the pseudoaneurysm generate. We have area of myocardial infarction, the rupture starts, but the inner part of the pericardium goes to contain the rupture and fills with blood. So this blood may coagulate and be part of this new wall, actually.
Yes, and they're kind of lucky that they don't die on the spot, but as I mentioned, they are at risk that this will rupture in a second event. So what is the characteristic of a pseudoaneurysm? First of all, they have a narrow neck. The outer wall is formed by pericardium and by mural thrombus. You will have sometimes a hematoma in the pericardial sac, and sometimes you have additional pericardial effusion. But as I mentioned, it's sometimes very difficult to see these morphologic abnormalities. Okay, and I have another advice for you. The infarction not only involves the walls, but sometimes also the papillary muscles.
Yes, and this is an example. I guess you notice there's a structure attached to the mitral valve, which is swinging back and forth from the left atrium to the ventricle and back. This is nothing else but a papillary muscle which has been ruptured. So this is a terrible complication of ME because the consequence is massive MR. So when you see something like this, you cannot have anything else but massive MR.
This is actually pretty difficult to diagnose at times because the patients are very unstable. They have pulmonary edema. Sometimes you need to stabilize them first, perform a TE, and diagnose the papillary muscle rupture with the help of TE.
Exactly. And apart from the papillary muscle, also the cord could rupture. The consequence is the same because a big part of the leaflets is in flail. So again, MR will be really relevant.
Right, so remember you can have a complete papillary muscle rupture or only partial papillary muscle rupture, and it's not the same thing as, for example, a chordal rupture that you would have in mitral valve prolapse. How do we differentiate the two? First of all, if you see a little part of the papillary muscle swinging back and forth, that's of course indicative of an infarct with papillary muscle rupture. And if you have an infarct and you have massive MR, always think about papillary muscle rupture.
So we've already seen the papillary muscles when imaging the left ventricle. Now we really want to focus on them. So there are two main views that allows you to image the papillary muscles. One is the personal long axis view. There's a little trick. When you get to your view, what you need to do is fan the transducer more cranially. As you see, I will optimize my image. And as you can see here, I don't see really good the papillary muscle. Sorry, but if I go more cranial, here they appear and we can really see how they are connected with the mitral valve thanks to the chordae. Then we can see really fast in the short axis view. You've learned this, but the other view I would actually use is the apical four-chamber view. And here also you will use another trick. So actually you will tilt your transducer a little bit more clockwise. And here you see, this is great to see the papillary muscle. You can use these views when you suspect papillary muscle rupture, but remember, you don't have only to look at morphology. When you suspect this disease, you also have to add color Doppler, because in this case you would have massive MR. Here is another advice. Myocardial infarction may involve also the right ventricle. So the right ventricle is usually not considered during the exam, but right ventricular infarction are mostly associated with inferior infarction. So 30 to 50% of the cases. And remember, while the mortality for the inferior infarction alone is 6%, it goes up to 30% when right ventricular infarction is associated.
Here's such an example, a patient who had an inferior infarct, and what you have to look for is, first of all, the size of the right ventricle. You see it's dilated, and if you visually assess right ventricle function, you will recognize that the patient has poor right ventricle function. So these are the key features in detecting a right ventricular infarct. Here's another example, two-chamber view, which shows you an infarct here. This is the scar. So actually the scar is relatively small, but the patient developed an infarct of the free right ventricular wall here. So this means that the patient has a poor prognosis.
And the last advice, follow up patients after myocardial infarction, because they can develop late complications. And here you have an example. This is a ventricular aneurysm.
Yes, a huge aneurysm in the inferior wall. You can see it nicely here. Maybe there's even a thrombus here, and associated with it is mitral regurgitation. All of these things are not good for the patient and for the ventricle.
Yes, and aneurysm can happen both in the inferior wall and in the apex. As a matter of fact, they are more common in the apex, and here you have an example.
This is a huge aneurysm, something you will not see very frequently. Actually, the ventricle should end somewhere here, and all of this is a huge sac. Imagine the amount of blood which is inside the ventricle here. This is a late complication that occurs and can be kind of put together into the group of remodeled ventricles. What does that mean? It means that over time, the ventricle gets larger and larger and larger to compensate for the dysfunctional part of the myocardium, and thereby develops heart failure and mitral annular dilatation and regurgitation, all sorts of things that you do not want to have in your patients.
But remember, usually chronic aneurysms do not rupture.
So this concludes the chapter on complications of myocardial infarction. You see the large variety of pathologies you can experience, but this is certainly not all. And we will collect more and more images and hope to put together an additional course that will give you more opportunity to see cases.